What's up, Ninja Nerds? In this video today, we're going to be talking about diabetes mellitus. This is a monster lecture. Let's get right into it. When we talk about the pathophysiology of diabetes mellitus, there is two. There's type 1 and type 2. And the pathophysiology does differ somewhat. So for type 1, the concept behind this is that it's usually in a younger individual. Usually you want to think age less than 30. That's not always the case, but it is most commonly going to be like this for your board exams. The other important thing to remember for this is that the pathophysiology is different in the sense that the beta cells, the pancreatic beta cells that are ones that are responsible for producing insulin, are being destroyed. And because of that, they're not going to be able to produce an adequate amount of insulin. So there'll be a reduction or deficiency of insulin in these patients. Now, with a reduction in insulin, what leads to the downstream consequences here is that insulin won't be able to bind on to its appropriate receptors, right? So these insulin receptors aren't going to be activated as much. What do these do? They're supposed to come down and tell this glucose transporter to allow for glucose to be brought easily into the cell and to be metabolized and undergo oxidation processes or glycogenesis, etc. However, since insulin isn't sending the signal appropriately, glucose will not be taken up into the cell, and instead it will remain in the bloodstream. It'll develop something called hyperglycemia. This is really the big pathophysiological difference. Now the question comes is what's leading to the destruction of the beta cells, correct? And it's usually an autoimmune attack of the beta cells. So there has been some associated like autoimmune diseases like celiac disease, maybe Hashimoto's thyroiditis that have been linked and very commonly associated with type 1 diabetes. The reason why is there's these certain types of like gene mutations in the HLA-DR3 and HLA-DR4 that may make the immune system a little bit more hyperactive than it should be. What do I mean? Well, let's say that a patient has these immune system cells. They become exposed to an environmental agent of some particular etiology. And what happens is this causes these immune system cells to inadvertently become hyperactive and produce lots of cytokines that then stimulate plasma cells. These plasma cells become stimulated in such a way that they start to make antibodies inappropriately. And these antibodies that are produced, they're going to start attacking proteins that unfortunately look like those environmental agents. And these proteins that they're going to attack is again against the beta cells, the cells that are producing insulin. So you'll produce these antibodies like the anti-GAD antibodies, which is a very critical enzyme within the beta cells that helps with the production of insulin. And these ones that actually go against the islet cells. Again, the islet cells of Langerhans are the cells of the pancreas that are, again, responsible for producing hormones, such as the beta cells and the alpha cells. So again, you're going to be destroying those cells, leading to the reduction in insulin. In comparison, type 2 diabetes mellitus, you want to think about this in a patient who is a little bit older. Usually the age is greater than 40, but it can happen in younger individuals, especially in the more modern era. What you really want to associate this with is more particularly metabolic syndrome. So in patients who are obese, they may have kind of a transition into this adipokine process where their fatty tissue is releasing adipokines and causing a lot of alterations within some of their metabolic parameters. For example, I may drop down my HDL. I may increase my triglycerides to greater than 150. My BP might start trending up to greater than 130 over 85. My blood glucose may start kind of going up to greater than 100. My waist circumference may start exceeding 40 if I'm a male, 35 if I'm a female. And if I have at least 3 out of 5 of these, I have what's called metabolic syndrome. So usually in patients who are a little bit older and have features of metabolic syndrome, what we've found is that these things alter the insulin receptors. In other words, it makes the insulin receptors less sensitive and more resistant to insulin. So what the heck does that mean? That means if these receptors are not responding to insulin, then they're not going to be as good at being able to stimulate this receptor that's supposed to take glucose up into the cell. And as a result, glucose will build up in the bloodstream. This is referred to as hyperglycemia. This high glucose will then tell the pancreatic beta cells, hey dude, glucose is pretty high here. You want to do something about it? And the beta cells will say, okay, I got you. I'm going to release a lot of insulin and other types of molecules. This insulin that's being released, though, you have to remember, it's not going to work properly on these tissue cells because, again, these receptors are less sensitive. Why? Likely because of metabolic syndrome. These particular factors that we just talked about above. So because of that, again, they're not going to take the glucose up into the cells. It's going to build up and they're starting to developing really bad high glucose levels. The other thing that's really important to remember here in these patients is that whenever the beta cells are pumping out tons of insulin, the other complication that we see here is that there's other proteins that are released called amyloid proteins. Amyloid proteins, whenever you're releasing tons and tons of insulin, you're releasing tons and tons of amyloid proteins. And these over time can lead to fibrosis and destruction of the actual beta cells, to the point where the beta cells die and they aren't able to produce enough insulin. And so that's the difference over time, is that initially in a patient who has type 2 diabetes, they'll have insulin resistance, hyperglycemia, and high insulin levels. But over time, with more amyloid deposition, their insulin levels will drop and they'll kind of start taking on the characteristics of a type 1 diabetic. So metabolic syndrome is going to be one of the big features here, but there's also been a lot of studies that have shown that family history can be accompanied to this. So there may be some type of genetic relationship here that causes an alteration in the sensitivity of the insulin receptors, not just these factors themselves. We know now that hyperglycemia is the common thread between type 1 and type 2 diabetes though, right? Now, oftentimes this will lead to the classic 3P presentation: polyuria, polyphagia, polydipsia. How? Well, hyperglycemia, whenever this happens, it actually is one of the solutes of our bloodstream. So it's going to lead to a change in what's called the osmolarity of the blood. With higher amounts of glucose comes a higher osmolarity. It's a part of our normal osmolarity calculation. So whenever our osmolarity goes up, there's a couple things that happen. One is it starts to activate the osmoreceptors in the hypothalamus, right? The subfornicular organ, the lamina terminalis. And what happens is when they become stimulated, they start causing an increase in our thirst. So now we're going to start getting thirsty, trying to drink tons and tons of water. Why? The concept is that if we drink more water, we'll then help to dilute down the amount of solutes in our bloodstream and reduce the osmolarity, all right? But you're still going to have hyperglycemia that will persist. The other concept is when patients have hyperglycemia, that sugar that's not getting taken into the cells will get filtered across the glomerulus into the kidney tubules. And what glucose is, it's an osmotic molecule, and it'll draw with it a ton of water. And these patients can have massive what's called osmotic diuresis and pee out very large volumes of urine, or they have to pee more frequently, and this is called polyuria. Problem with this is that now not only is your sugar going up, which is causing an increase in your hyperosmolarity, but you're also getting rid of a ton of water. And if I pee out a ton of water, the amount of water I have in my bloodstream starts going down because I'm becoming dehydrated. So now I have high glucose and low water. That's going to make even more hyperosmolar and make me even more thirsty. So it's a very vicious cycle. The polyphagia one's very interesting. In these patients, they're not utilizing the main source of kind of fuel, which is the carbohydrates. And so because of that, they start tapping into alternative sources. They start breaking down proteins in particular tissues, and they start breaking down fats in other tissues because they need that to generate ATP. So as I break down proteins and I break down lipids, I start chewing through this metabolic kind of fuels, and this could lead to a catabolic state that leads to increased hunger. Because as I start kind of breaking down all these molecules, right, I'm going to increase my metabolism, increase my heat generation, and this will start causing the people to be much more hungry, right? So this is another thing to also consider. And usually in type 1 diabetics, this hypercatabolic state can be so insane that they actually could be have weight loss. So they actually can lose weight in type 1s. All right, that's a lot of stuff to talk about with diabetes with the pathophys, but I think it really sets us up for the next part here, which is what are some of the complications and the scary issues that can arise in patients with diabetes mellitus where they live with this very chronically high glucose, or in the scary scenarios, they have very acute rise of glucose. So there's something that you really need to remember, and this is called DKA and HHS. This is a part of our hyperglycemic crisis. And a patient who has diabetes, and they experience an infection. Maybe they have a myocardial infarction. They have pancreatitis, or they have some type of like surgical procedure of some sort. What happens is that in these states, you create a stress response. That stress response will then increase the release of your catecholamines like norepinephrine and epinephrine via the sympathetic nervous system, and it'll also increase the release of cortisol. Both of these guys are bad news bears, especially in a patient with diabetes. You want to know why? Because they're going to increase glycogenolysis, gluconeogenesis, and they are going to lead to a very high glucose level. And when you have a high glucose level in a patient who already has diabetes, you have a recipe for some disaster, such as DKA and HHS, diabetic ketoacidosis, and hyperglycemic hyperosmolar syndrome. Now, we have to differentiate between these two, so let's talk about that. So first one's DKA. I like to remember more particularly that DKA is going to be something that's more likely to be seen in type 1 diabetics. It can be seen in type 2 diabetics, but it's much more common in type 1s. The concept behind diabetic ketoacidosis is that the pancreatic beta cells are not making insulin. If you're not making insulin, the concept behind this is that you're not going to be taking glucose up into the cells. If you don't take glucose up into the cells, your body has to start tapping into an alternative source to generate ATP. And that's usually it starts chewing through fats. And it does this through a process called ketogenesis. So what happens is you start breaking down lipids in your adipose tissue and in your liver. What happens is those fatty acids get taken up into your liver and it starts chewing through them via a process called beta oxidation. Unfortunately, when you take fatty acids and convert it into acetyl-CoA, you may be doing way too many of them that acetyl-CoA gets kind of built up and it can't go into the Krebs cycle. So what happens is it shunts into an alternative cycle, which is making ketone bodies like beta-hydroxybutyrate and acetoacetate. These ketone bodies are problematic. The reason why is that they can kind of cause, especially the acetone, which is one of the products of the ketone bodies, they can cause the breath to be very fruity. The other thing is that they can actually release protons. And when it releases protons, it drops the pH of the blood. And it can actually cause metabolic acidosis. And these are kind of organic acids, so they have the capability of causing an anion gap metabolic acidosis, where the anion gap is greater than 12 and the pH is very low, less than 7.35. The other thing is because they're super acidotic, this actually stimulates the peripheral chemoreceptors and tells the patient to breathe faster, to hopefully breathe off more CO2, and then by doing that, hopefully you'll bring up the pH. So oftentimes as a result, these patients are breathing very fast, and we call this Kussmaul breathing, very deep and fast breathing. Going back to the problem with having less insulin is that you don't take glucose up into the cells, and so their glucose goes up as well. And this glucose can be pretty high, sometimes greater than like 250 when a patient with DKA. So if I have type 1 diabetes, I have ketoacidosis and hyperglycemia, that really kind of gives me the recipe for a patient having DKA. Other things that are really important to remember with these patients with DKA that are complications is when you have very, very high glucose, it actually has the capability of kind of pulling potassium out of the cells. And so you can get a really total body potassium depletion. Another thing is that it's going to cause osmotic diuresis. When you have lots of glucose into the bloodstream, it gets filtered into the kidneys. It's going to pull a ton of water with it. And these patients can develop massive polyuria and dehydration. Now, with that being said, we go to HHS. HHS is hyperglycemic hyperosmolar syndrome. I want you to think type 2 diabetics. Now, remember I told you that DKA, it is more common in type 1. You can see it in type 2, but it's usually at the end stage when the insulin levels pretty much dropped. In HHS, I'm thinking early type 2 diabetics. Now, in this particular scenario, pancreatic beta cells are still producing insulin. It's just not a sufficient amount, right? But you're still producing to some of this to some degree. Problem is that it is enough insulin for your body to use some of the glucose, but it's not the problem enough where you'll actually start kind of tapping in to the ketone body formation. So that's the big difference. They'll have enough insulin that they don't have to tap into the liver and start generating ketone bodies. That's one huge difference between HHS and DKA, is that there is no ketogenesis. So there's not going to be any Kussmaul breathing. There's not going to be any anion gap metabolic acidosis. There's not going to be any fruity breath. But you are going to have all the other complications, such as insulin resistance, where they're not going to respond to the insulin. They're not going to take the glucose input into the cell. It builds up in the bloodstream. You pull potassium out of the cells and deplete your total body potassium. You cause a lot of water to be lost into the urine and cause polyuria and dehydration. The last thing that's really interesting here in these patients is that their glucose can be so high, greater than 600 milligrams sometimes, to the point where it can cause the osmolality of the blood to start exceeding 320. And the problem with this is this starts causing encephalopathy. Patients start literally becoming confused, delirious, altered with respect to their mental status. And that's a really big difference here. So you're not going to see this kind of effect as clear as you would see DKA, and you're not going to see ketoacidosis and HHS as well. To really kind of recap this, I think the big thing to remember here is in between these two is type 1, type 2. Again, when we're thinking about DKA, it's more likely type 1, HHS, more likely type 2. Which one's going to have more significant hyperglycemia? HHS can get up into the 600s or greater. DKA can get up above greater than 250. Dehydration, HHS is going to be profound hyperglycemia that's going to cause significant osmotic diuresis, polyuria, and profound dehydration. DKA, they will be dehydrated, but not as significantly. Ketoacidosis, you're going to see that in DKA because they don't have any insulin. HHS, you get a little bit of insulin, enough that you don't have to tap into the ketone bodies. Hyperosmolarity, you're going to see a very high hyperosmolarity, almost greater than 320 for patients who have HHS, not as severe in patients with DKA. The other thing is DKA is usually rapid. So these patients, they develop severe hyperglycemia, ketoacidosis, dehydration, etc., whereas HHS is more of a gradual, slow, insidious onset. All right, that covers the hyperglycemic crisis, which is one of the most terrifying complications of diabetes. What about the more chronic, like macrovascular complications that you can experience if the patient has chronic hyperglycemia? So one of the big things to remember is if, again, your patient has like no insulin or they're having insulin resistance, whatever this, the issue is, they're not taking glucose into the cell, so they're living with hyperglycemia. One of the problems with hyperglycemia is that it can actually trigger something called non-enzymatic glycation. In other words, you can take proteins and lipids and bind glucose onto them. Problem with this is that this really accelerates atherosclerosis. Whether it be hyaline or basement membrane thickening, you're really causing damage to the blood vessels. The blood vessels become more thick and they become more high risk for atherosclerosis. The problem with having atherosclerosis is now that this patient can have plaqued up vessels that supply their brain. They can end up with a TIA or a stroke. They can end up with potentially coronary artery disease from plaqued up coronary arteries. In severe cases, they even have very high risk of a myocardial infarction. And on top of that, they also can plaque up some of the vessels that supply their lower extremities and end up with peripheral artery disease in the form of claudication or sometimes severe ulcers that can even become infected and even chronic limb ischemia. These are what we call macrovascular complications. So big things like strokes, TIA, again, myocardial infarction, CAD, PAD, critical limb ischemia. There's other vessels that can become atherosclerotic and they can cause injury, but particularly more at the smaller microscopic level. This is going to be something that we call diabetic nephropathy and retinopathy. So when patients have diabetic nephropathy, you actually cause damage to particularly to the glomerulus, and a lot of injury to the glomerulus sclerosis starts to occur. And as a result, these patients have difficulty being able to excrete waste products. And also they lead to a lot of loss of albumin due to damage to their nephrons. So you'll see these patients will have a significant increased risk of developing chronic kidney disease. And we'll see that based on an increase in their GFR, as well as a very significant loss of albumin in their urine. Retinopathy is another one. They can really cause a lot of damage to the blood vessels and plaque these puppies up. So these patients can start off with maybe like little microaneurysms. They can cause hard exudates, which are these kind of like little lesions that kind of occur outside of the vessels in the retinal tissue. They can cause flame hemorrhages and cotton wool spots, but the worst case scenario is when they start having to form new blood vessels to get around the damaged blood vessels. And that's called proliferative or neovascularization. So this is a type of proliferative retinopathy, and all of these are non-proliferative retinopathy. These patients can start to come in with visual changes, and that's pretty bad. All right. So watch out for patients who start having a bump in their GFR, an increase in their albumin. Watch out for any evidence of macrovascular complications such as neurological deficits, angina and ST changes and potentially troponin elevations, claudications, ulcers, and then again, retinopathy with vision changes. Another complication that could be very significant is neuropathy. This is actually really interesting. The concept behind this is that glucose, whenever it's in really high amounts, it gets into your cells. And what it does is it can actually increase the amount of sorbitol. Now, sorbitol, the problem with this thing is that it loves to pull water into the cells. As you pull a lot of water into the cells via its osmotic kind of its osmotic characteristics, it can lead to these cells dying because of the osmotic damage. When that happens, the cells that are really kind of being affected by this is the Schwann cells, which are significant to your actual peripheral nervous system. So oftentimes these patients can develop what's called neuropathy, peripheral neuropathy. That's called diabetic neuropathy. Now, ways that this can present is that it alters the sensation from the lower extremities, and they can develop paresthesias, and sometimes in the worst case scenarios, they lose all complete sensation to their lower extremities, usually in what's called a stocking glove type of pattern. The problem with this is if you lose sensation to your lower extremities, and as a patient who goes around, maybe you step on something, you hit your leg against something, you start getting sores or ulcers that form on your foot, you may not even know that they're there. The problem with this is that these diabetic foot ulcers are very high risk for infection, especially in a patient who has diabetes. Why? Because diabetes accelerates the risk of PAD. So if a patient has peripheral artery disease, they won't give good oxygen to their tissues, they have increased risk of ulcers, and now this thing can become infected and even potentially progress to gangrenous necrosis. And that's a very important thing to remember. The other concept here is that it also alters the neurons that supply the stomach. And so these patients may have difficulty being able to generate enough profound contraction of their stomach and empty the contents of their stomach. And so because of that, they may present with what's called gastroparesis. So they may present with nausea, vomiting, stomach dilation, and this is potentially common as well. The last one is what's called orthostatic hypotension. This one's due to kind of an autonomic nervous system neuropathy. So you kind of demyelinate some of the autonomic neurons. And so what happens is your sympathetic nervous system is supposed to provide vasoconstriction to your veins and to your arteries. If a patient is not getting enough good venoconstriction, they're not going to be able to squeeze their veins and return enough blood to their right heart, maintain a good venous return, stroke volume, blood pressure, and they won't be able to perfuse their brain as well. So because of that, if you have a patient who has some type of autonomic neuropathy because you demyelinated their sympathetic neurons, they won't get good venoconstriction, they won't have good venous return, they won't have a good stroke volume, cardiac output, blood pressure, and they could end up with syncope. Or they could end up, whenever they stand up, they start getting lightheaded and presyncopal. So this is very common complications in patients with diabetes. We talked a lot about the complications, right? I think the next thing to go to is, okay, I have a patient comes in, polyuria, polydipsia, polyphagia. Maybe they come in with a hyperglycemic crisis like DKA, HHS. They have common atherosclerotic cardiovascular disease. Maybe they had a TIA, a stroke. Maybe they also had a heart attack, or a myocardial infarction is the proper term. Maybe they have they have peripheral artery disease. On top of that, they're coming in with neuropathy, so they have sensory losses. They have ulcers on their foot. Maybe they have kidney disease, so they're having an increased GFR, a lot of albumin loss. They're having visual changes, and now they're having blurry vision and maybe even complete vision loss or retinal detachments. In these particular scenarios, it's important to consider diabetes as the cause. So what we'll do is for these patients is we'll look for findings of hyperglycemia. So if they have the polyuria, the polydipsia, and the polyphagia, or do they have lots of foot ulcers, infections? Do they have any atherosclerotic cardiovascular disease factors? All those things that we talked about. If they don't, and it's more insidious, then it's kind of important to obtain 3 particular tests. You want to get a fasting plasma glucose level, a 2-hour oral glucose tolerance test. This one's a little bit more specific for gestational diabetes, but we'll talk about it. And then lastly, the most clear test is the hemoglobin A1C. From these, this will give you an idea if the patient has diabetes or not. If the fasting plasma glucose level is greater than or equal to 126 milligrams per DL, that means that they're living with a high glucose pretty much without any food in them. So that's definitely diagnostic. If the blood glucose is greater than or equal to 200 after you give them a little bit of sugar, that's definitely indicative of diabetes. And then lastly, if their A1C is greater than or equal to 6.5%, that tells me that they're living with a high sugar, pretty decently high sugar, that you can extrapolate over a period of 3 months. And that's one of the benefits of A1C. It's a little bit better at being able to tell you the long-term effect, or at least a 3-month time frame of what their sugars have looked like. If they have these, you have diabetes, right? You can go further if you want to say, I want to see if it's type 1 or type 2. Oftentimes you can gain that from history, but if you want to go the length of determining if it really is type 1, type 2, you can obtain something called a C-peptide and antibodies. Before we talk about that though, let's say that we have a patient who comes in with polyuria, polyphagia, polydipsia, or other concerning findings that suggest diabetes. From that, you can get a random plasma glucose. And if the random plasma glucose on at least 2 occasions is greater than or equal to 200 milligrams per DL plus symptoms, it's likely diagnostic of diabetes. Now let's say that you're not sure. Is it type 1, type 2? Again, history usually can elucidate this, but if not, you can obtain the C-peptide. Oftentimes the antibodies, the anti-GAD, anti-islet, those are going to be present in type 1. You're not going to see that really in type 2. The other thing is the C-peptide levels. Those should be lower generally in a patient who has type 1 diabetes. Also look at the history. Are they less than 30, greater than 40? That also may provide some effect. This would suggest more of a type 1. In the other scenario where I think the patient has type 2, the antibodies should technically be negative. they're going to have more of the characteristics of metabolic syndrome. So obesity, low HDL, high triglycerides, high BP, high sugar, increased waist circumference. And oftentimes their C-peptide in the initial periods are going to be high. So C-peptide is kind of like one of the molecules that gets released with insulin. And patients who have type 2 diabetes, they release a lot of insulin. It's just they are insulin resistant. So if they release a lot of insulin, they'll release a lot of C-peptide. If you don't release a lot of insulin, you don't release a lot of C-peptide. All right. How do we treat diabetes? Well, type 1, they're just not making insulin, so you got to give them insulin. That's pretty straightforward for this one. So there's different types of insulin. We'll go through this briefly. There is what's called rapid-acting insulin in the form of Lispro and Aspart. Lispro is the more commonly utilized one. The duration for these are pretty short. So because of that, if they're very, very short acting, the best time to give them is usually for meals. So whenever a person's going to be eating breakfast or lunch or dinner, we should be giving it around those times to help them to control that sugar spike whenever they eat. So again, this is best for whenever their patient is going to about to eat. The other one is a short-acting insulin. So this one's going to be the regular insulin. Its duration's a little bit longer, not significantly longer, but it's a little bit longer. Problem with this is it's a little bit too long for a patient, eating, and it's not long enough that it's going to last an entire day for their basal insulin. So really the only time where we really use short-acting insulin is in a hyperglycemic crisis. So this is going to be more fitting for a patient who's going to be on an infusion that we can titrate every single hour. And so for patients who come in with DKA or HHS are very, very difficult to control, type 1 diabetes mellitus, we may put them on an insulin infusion to get a little bit more better control, and then we can extrapolate how much insulin they're on that infusion, and then switch them over to a rapid-acting and a long-acting insulin. There's another one, it's a little bit cheaper and it's more commonly utilized because of that. It's called intermediate-acting insulin, also known as NPH. And this one, Humulin, it can have a little bit of a longer period in comparison to the regular insulin. Problem is it's not going to last 24 hours. So this can be used as a basal insulin, meaning that you're going to give it and it may give you a pretty good extent of time where the sugars are relatively stable. However, you're going to have to give probably 2 doses of it. So you may need it twice a day. So it's not commonly utilized, but it is a little bit cheaper. These are going to be the more commonly utilized one, which is the long-acting ones, Glargine and Detamir. Glargine is probably the more likely one that you'll see. These have no peak. They're pretty stable. And as you can see here, it's kind of got a plateau phase that it's pretty good, and it can last a decent amount of time. So about 24 hours. So to give you a full day's length of insulin, that's kind of like your baseline. And if you think about this, this would be really good for insulin that you can give maybe at the end of the night, or maybe you can give it around lunchtime, around 12 o'clock. And this should give you a very long coverage of the entire 24-hour period. So this may seem like a lot. You're like, okay, what am I supposed to do with this to treat them? I don't know. I know that if they got really high glucose, I'll put them on an insulin infusion. I know that this is I give them with the meals. I know I could give one of these two potentially with, once a day or twice a day. I don't really understand, Zach. How do I do this? I got you. The basic concept here is we use something called a basal bolus regimen. So if we're putting them on an infusion, we just monitor this every hour and we titrate to their glucose. For these, we're going to more commonly base it off of their weight and their A1C. So in a basal bolus regimen, you're going to take their weight and they're going to multiply it by a factor. This factor is variable. So a patient who's like, you're just starting them on insulin, 0.3, 0.5 is okay. If a patient has really high A1C, you may need a 0.7 or 1. And that's something that really depends from patient to patient. But let's say that you start off with this. When you do this, this will give you a number that tells you the total amount of insulin that you can give them for a day. All right, so it's a total daily dose. So what I'm going to do is I'm going to split this into 2 parts. The one that I'm going to give them that's going to last them 24 hours, and the one that I'm going to give them that'll last for particularly whenever they eat. So I'm going to split this in half. When I split it in half of it's going to be the Glargine dose. That's my long-acting insulin that'll give me the entire 24-hour period. Then I'm going to take the other half, and that's going to be my Lispro dose. That's my rapid-acting that I'm going to give them with the meals. But I have about 3 meals a day. Maybe I'm going to eat breakfast, lunch, and dinner. I'm going to take this dose, and I'm going to split it up over 3 meals. So maybe it was a total of 12 units. I'm going to divide that by 3 and 4 units at breakfast, 4 units at lunch, 4 units at dinner. And then for this one, I'm maybe going to give 12 units. I'll give it around 12 o'clock, and that's going to last me until 12 o'clock the next day. That's the concept behind this. The important thing to remember is when you start them on this, you should kind of track their glucoses, maybe again at breakfast, at lunch, at dinner, and right before you go to bed to make sure that they're appropriately within a good range and you don't have to modify these a little bit. But this is how we would treat type 1 diabetes. Again, the alternative is I could say instead of me using glargine, I could use NPH here. It's just I would have to potentially give it twice a day rather than once a day. All right, what about type 2 diabetes? Well, they're still making insulin, so I don't need to give them insulin. There is a couple exceptions where I could, but oftentimes we just need to try to improve insulin resistance. So oftentimes it is changing up the lifestyle, right? Trying to treat the metabolic syndrome, losing weight, reducing caloric intake, etc. But unfortunately with these patients, they're going to require anti-diabetic medications to some degree. The most common one that we'll start off with is a biguanide. It's metformin. It's usually the first line medication. So we'll start them on that, and then 3 months what we'll do is we'll get an A1C because it's going to tell me where their sugars have been for at least a 3-month period. Remember, greater than or equal to 6.5% is considered diabetes, right? At this point, I want to just know if they're being better controlled. So I'm going to use an arbitrary number such as 7%. This is what we've been shown in the guidelines. If a patient gets that A1C though, and I see that after I put them on metformin for 3 months, their A1C is greater than 9.5%, there's not a chance in heck that if I put them on a second anti-diabetic medication, I'm going to get them from 9.5 down to like less than 7. So at this point, if it's greater than 9.5%, just start them on basal insulin. So you're going to put them on something like glargine, or you're going to put them on something like degludec or NPH potentially. And this is going to give you a little bit more extended coverage to try to bring that glucose down and have a basal control of their sugar. If the A1C is greater than 7%, it means, okay, I know that I started metformin, I'm still not less than 7%. I want to get less than 7%. That's my goal. If I'm not there yet, I got to add on a second agent. All right, so if I'm greater than 7, but I'm still less than 9.5, I'm going to add on a second anti-diabetic. All right, well, what's that one? There's a lot of them, and it's really based upon the patient's underlying diseases or what they're trying to do. So let's say that the patient has coronary artery disease, they have a history of a TIA or a stroke, they have peripheral artery disease. In these particular scenarios, there is a couple drugs that actually may help with that. GLP-1 agonists, semaglutide, liraglutide, these potentially can provide a lot of benefit there. SGLT2 inhibitors like your flozins, these can also be potentially beneficial. The other one is if a patient has underlying CHF. If a patient has CHF, we have seen that particularly SGLT2 inhibitors are very, very effective, and they can be a part of what's called your guideline-directed medical therapy. The one that you should never give to a patient with CHF because it's been shown to potentially worsen it is thiazolidine diones. So stay away from those. If a patient has CKD, we know that SGLT2 inhibitors and GLP-1 agonists are pretty good for these patients. If they are looking to lose weight, we know that SGLT2s, GLP-1s, and DPP-4 inhibitors have been shown to be good for weight loss. So if your goal is to treat your athero or the atherosclerosis related diseases, these should be initiated. If it's CHF, this one. If it's CKD, this one. And if it's weight loss, it's this one. So you notice a trend. The most commonly utilized ones here as a second line agent is GLP-1 agonists or SGLT2 inhibitors, and maybe a DPP-4 inhibitor. The other one is if you don't want to have a lot of periods of hypoglycemia, because these can cause like neuroglycopenic symptoms. You can become diaphoretic. You can actually go into a comatose state from severe hypoglycemia. So it's important to be able to give drugs that you want to do to reduce that risk. GLP-1 agonists are really good at not having a lot of hypoglycemia, DPP-4 inhibitors, SGLT2 inhibitors, and thiazolidine diones. So with that being said, the one that does have a risk of hypoglycemia and you probably don't want to actually take is sulfonylureas. The benefit to sulfonylureas are they are a little bit more cheaper, so that's going to be one of the reasons why that they could be considered. So glyburide and glimepiride. All right. So let's say that I start the second anti-diabetic and I base it upon one of these particular factors. You're seeing a trend though that SGLT2s and GLP-1s are really the best in a lot of scenarios here. So I start them on one of those. I get an A1C in 3 months and then I check. If my A1C is greater than 9.5, there's not a chance that adding a third anti-diabetic is going to get me that love to bring the A1C less than 7%. Start the basal insulin, all right? Get a little bit more baseline control of their sugars. If it is still greater than 7 but less than 9.5, I can be a little bit more aggressive and I can add on a third anti-diabetic. So let's say I started them on metformin, A1C still greater than 7% after 3 months, start them on a GLP-1 agonist, A1C still greater than 7% after 3 months, start them on an SGLT2 inhibitor. If after that, in 3 months, I check it and their A1C is still greater than 7%, you got to then add on you got to add on insulin. So that's what we would do in this particular scenario of treating a patient with type 2 diabetes. Start off with metformin, go to a second antidiabetic if you're not meeting your goal, then a third antidiabetic if you're not meeting your goal, and then insulin if you haven't met your goal with 3 antidiabetics. If along any point in that time frame, your A1C is greater than 9.5%, start them on basal insulin. All right, the last thing here is treating the complications of diabetes mellitus. There is a lot of these, but the most concerning ones is DKA and HHS. So let's talk about how do we treat this. Well, first thing is these patients are severely dehydrated from the osmotic diuresis. So because of that, you want to replace their volume losses. And oftentimes, these are patients that can require like 3 to 4 liters of fluid, so they should be seen in an ICU. Oftentimes, we start them on an infusion. We may give them like a bolus of fluid, maybe 1 or 2 liters like in a bolus, and then we'll start them on a very high maintenance rate, maybe 120, 150 milliliters an hour. The two choices I'd say that are best is half normal saline and LR. The only reason why is that normal saline itself can cause a little bit of a normal anion gap metabolic acidosis. And if a patient's already acidotic from DKA, you can worsen their acidosis. So you're going to start giving them some boluses and then start them on a maintenance rate to replace their actual dehydration. The next thing is you have to ask yourself the question, I'm about to start insulin for this patient. What's their potassium? So get a BMP, check what their potassium is. The reason why is you can't start the insulin infusion unless their potassium is normal. So if I check it and the potassium is low, give them potassium first, replace that. Then after the potassium is normalized, then you can go ahead and initiate an insulin infusion. And again, the type of insulin is not going to be the rapid acting. It's not going to be the intermediate, the long acting. It is the regular insulin. All right. So in this particular scenario, if I start them off on regular insulin, here's what we do this for, because oftentimes I think there's a misconception of how we give them insulin. When we start the insulin infusion, we start it off at a particular portion, and we're going to continue to up titrate the insulin, not to glucose. We're titrating it to the anion gap. So you're going to be monitoring these patients' BMP like every 2 hours. So they're going to be getting frequent lab draws. You start the insulin infusion, their anion gap is like 20. You get the insulin, you check in 2 hours, their anion gap's 18. All right, you're kind of bringing the anion gap down. But if the anion gap is still present, you need to then increase the insulin infusion rate so that you can keep bringing down the anion gap, because insulin is going to start kind of shutting down the ketogenesis process. So if the anion gap closed, great. You don't need to have them on regular insulin infusion anymore. You can just put them over onto the basal bolus and stop the infusion. But if their insulin, if their anion gap is still potentially present, say that you went from 20 to 18, you have to keep them on the insulin infusion. You might even have to increase the rate. Now, if I increase the rate of the insulin, I also have to bolus them with more insulin. So again, start off with fluids, check their potassium. If it's normal, start the insulin infusion, check their anion gap via their BMP every 2 hours. If I check it and it completely normalized, it's less than 12, you can stop the infusion. You're good. And you can just treat them with basal bolus. If you do it and the BMP shows that your anion gap is still elevated, you have to increase the rate of your insulin infusion and then rebolus them with insulin. Keep checking their BMP every 2 hours. During that time frame, you should also consider maybe getting ABGs or VBGs. If a patient is severely acidotic, a pH less than 7, that's really bad, and that can actually start altering a lot of problems. That can lead to a lot of problems. It can lead to poor response to vasopressors. It can even worsen a lot of your potassium derangements. And so in this situation, if the pH is less than 7, you should give this patient bicarbonate, and that's the only time. The other thing is you have to kind of think about this. In a patient who has diabetic ketoacidosis, you're giving them a lot of insulin. That's going to start bringing down their glucose. That's not what you're doing it for. You're doing it to bring down their ketoacidosis. But unfortunately, it may take some time to bring their ketoacidosis down. So as you're bringing down their ketoacidosis, their glucose may be really low. And you need to keep giving them more insulin. And the problem with that is if I give more insulin, I'm going to cause them to become hypoglycemic. So if the blood glucose drops to less than 200 and your anion gap is still not completely closed, I have to give them sugar in order for me to give them insulin. So what you're going to do is you already have them on like 125 or 150 of LR or half normal, add D5 into it. And that'll help to increase their sugar so that you can give them more insulin to bring down their ketoacidosis and close their anion gap. I know that's a lot of stuff. I hope that part made sense. For HHS, you're actually not going to do an insulin infusion for the ketoacidosis. You're doing it directly for the patient's hyperglycemia and hyperosmolarity. But the same thing, these patients are severely volume dehydrated. Give them IV fluids in the form of LR half normal, give them a couple boluses, and then start them on an infusion. Again, insulin infusion is for hyperglycemia, so you actually are going to titrate it every hour off of their glucose level. And then the other thing is you're going to check their osmolarity to make sure that you're not dropping them down too quick. And then again, make sure that you're giving them potassium, because as you give insulin, again, insulin will cause the shifting of potassium into the cells, which can worsen their hypokalemia. That's why you never start an insulin infusion if they are hypokalemic, because then they'll start becoming super tachycardic. The other thing that you want to manage for these patients is the more chronic complications, such as retinopathy. It's more prevention, right? So you're going to do annual eye exams looking to see if they have any evidence of, microaneurysms, flame hemorrhages, hard exudates, cotton wool spots, proliferative neovascularization. And if you do catch that, you should actually start, again, controlling their glucose, but more specifically doing things that can prevent further injury, because that neovascularization can cause hemorrhaging. So oftentimes we'll do VEGF inhibitors, which will inject right there into the actual eye, and that's been shown to potentially reduce the proliferation process. Sometimes you can do laser photocoagulation if the VEGF is not an option. Another one is nephropathy. We want to be able to catch a patient developing nephropathy. And so if a patient has diabetes, you want to do annual urine albumin creatinine ratios to see if their albumin is really becoming high in their urine. And then check their BNP to see if their GFR is really starting to decline. Because in these situations, we should actually start them on drugs that can protect them from albuminuria, protect them from CKD, and maybe even control their blood pressure. So there's two drugs, ACE inhibitors or ARBs, one of them. What they do is they actually help to kind of promote this change in the efferent arteriole. They actually cause efferent arterial vasodilation, so they stop constriction, and they help to reduce the intraglomerular pressure, reduce the GFR, and that helps to reduce a lot of the albumin loss. Unfortunately, though, if you drop the GFR, you can worsen their kind of kidneys a little bit and cause a bump in their creatinine. But it's something that you have to use because it has been shown to be nephroprotective, reduce albuminuria, reduce the progression of CKD, and also can treat a patient who has hypertension. All right? The goal that you're trying to do here is you're trying to make sure they're not dumping enough protein into the urine. So the goal is to get that urine albumin creatinine ratio less than 30. You don't want it from 30 to 300. You definitely don't want it greater than 300. The neuropathy is all about, again, making sure that they are very aware of their sensations. So doing annual foot exams with a licensed podiatrist would actually be very good to see if there is any kind of like diabetic ulcers, to also examine to see, do they have diabetic ulcers from neuropathy, or do they also have concomitant PAD that's also caused some ulcers? Because you want to be able to recognize those before the patient starts having problems. The other thing is that they can cause a lot of pain. And so for the pain that they have, oftentimes gabapentin and pregabalin can be alternatives to treat the neuropathic pain. But if they also have concomitant depression, TCAs or SNRIs can be utilized if they have concomitant depression. Atherosclerosis is, again, a very, very important thing because diabetes has a very high rate of atherosclerosis. So because of this, the macrovascular complications are really important to prevent. So what we should be doing for these patients is getting an annual lipid panel to make sure that we're screening for any incidence of high LDL, low HDL, and making sure that if we recognize that, we start them on the appropriate therapy. One of the reasons why is, again, the indication for statins come from the literature that's saying if a patient does have diabetes, they are 40 to 75, and they have an atherosclerotic cardiovascular disease risk that's greater than 10%, they're at high risk for atherosclerosis, and they should probably be started on a statin. The concept here is you just really want to reduce this type of process, but also you want to reduce the risk of this plaque rupturing, a platelet sticking to it, causing a clot on top of that. So the other question is do they have indications for aspirin? If a patient has any clinical risk of atherosclerotic cardiovascular disease and you're trying to prevent them from having that, aspirin could be a potential indication here. But again, statins is really something that you have to have a very low threshold to start in a patient with diabetes. Because again, the goal is to try to prevent plaque thrombosis and the complications like a stroke, an MI, and critical limb ischemia. Oftentimes, if they're 40, greater than that, they have diabetes, and their atherosclerotic cardiovascular disease risk is greater than 10%, you should start them on a statin and also consider aspirin. All right, my friends, that was a monster lecture on diabetes. I hope it made sense. I hope that you guys really did enjoy it. Love you, thank you, and as always, until next time.